be talking a lot about prescription monitoring program. And before that, just a little intro about myself. So my name is Jessica McGuire. I have been with the Oklahoma Bureau of Narcotics for over 4 years now. So I have worked with the prescription monitoring program as the PMP administrator the entire time. And we have fortunately had a lot of different changes and improvements to the system over time, which we'll talk a little bit about that. So we're going to go ahead and get started. Hopefully you get something out of this. And then if there's specific questions, like Casey said, make sure to put them in there. And my contact information is also at the end in case you want to contact me directly. So like I said, we're going to specifically talk about the Oklahoma prescription monitoring program. We are going to talk about a kind of the overview. We're going to start with an overview of the history of the PMP and kind of get you an idea of how it all came about and how it all started. So in 1990, Oklahoma actually established the first electronic prescription monitoring program. We were the first in the nation. Prescription monitoring programs had been around for years and years before that. So it's not anything new, but how they used to do it, it was a triplicate. So you would have a prescription pad that came in triplicates. The doctor would keep a record. Then the patient would take the other two to the pharmacy. The pharmacy would keep one for a record, and then they would mail one in to the agency that actually regulated the prescriptions and ran the prescription monitoring program. So as you can imagine, having boxes and boxes of different scripts is probably not the most efficient. We were the first electronic one, and then ever since then, it's been electronic throughout the whole United States. It began as just Schedule IIs because, as you all know, or even if you don't know, Schedule IIs are considered the most addictive prescription drug. Obviously you have Schedule I as well, but of the prescription drugs, it has the highest risk of addiction and overdose. So these are things like oxycodone. At this point in time, hydrocodone was not one, but you have also like Adderall, Ritalin, morphine, fentanyl, those types of drugs. And it was reported every 30 days. For those that may be on the older of the generations, we actually got them sent to us on floppy disks. So if you know what those are, then you'll kind of have a little throwback to back in the day whenever you were using your floppies. So we actually had them mailed
That's
to
brave,
us.
Jessica, very brave.
Right. So we had floppy disks mailed to us, and we would put those into our computer and we'd download the data. And you can imagine a pharmacy is probably sending us a whole stack of floppy drives to be able to upload for a 30-day supply of Schedule II drugs. Then in 2006, we actually increased it to 2 through 5, so 2, 3, 4, and 5 prescription drugs. By this time, though, we didn't have to worry about floppy drives anymore and things. They were all just submitting it electronically, automatically, but it was still every 30 days. A lot can happen in 30 days, unfortunately. So you can have someone fill many different scripts. They can have a forgery ring where you would actually be able to go online, download a list of DEA numbers, buy prescription paper, or get a printer and print off prescriptions. And you'd be able to run around town. And how we have pharmacies set up is you have a Walgreens and a Walmart and a CVS, like sometimes right across the street from each other. So they could just park at one, walk across the street, fill the script at all these 3 different pharmacies in just a matter of seconds. So in 2010, it was changed to 24 hours. So within 24 hours, it's reported. But in 2010, we told pharmacies, this is 24 hours for 2 years. Get your stuff together. Make sure you do all the programming you need, because by 2012, it's going to be in real time, which we define real time as within 5 minutes. It's a lot more difficult to actually try to fill forgeries when the data is being submitted within 5 minutes. You're not going to be able to get your script and walk across the street to then get in line to fill another script, and 5 minutes has already passed by then. So this really ended up making forgeries basically non-existent. 2015 is actually when prescribers were required to check for opioids, benzos, somas. This doesn't include, just includes like private practice type people. So federal, tribal, those types of stuff. aren't actually required to. However, they do all the time. I mean, we have literally hundreds and hundreds of tribal and IHS prescribers who use the PMP all the time. And the most recent change to the system outside of just improvements and upgrades was in 2016. We switched to our current system that we use today. So a little bit about a lot of people have questions about like, well, what is this data? Where does it come from? How do we know it's any good and things like that? So a little bit about the data. So PMP data, even though it's called prescription monitoring, it's technically not prescriptions. It's technically dispensations. So, you can get a prescription from your doctor and you don't have to fill it. I mean, a lot of people have gotten prescriptions from their doctor just because the doctor's just like, here, let me write this for you. And then you're like, yeah, I don't need pain meds. I'm fine. I'll take Tylenol and some ice. And then you just rip it up, throw it away or whatever. So it's actually dispensation. So a dispensation is either from a pharmacy or a dispensing physician. There's some weight loss clinics or testosterone clinics, those types of things that do dispensation, and veterinarians too. I mean, you can go, your animal has to have surgery or something like that. The vet a lot of times will also have controlled substances and they'll dispense them to you. They're the ones that actually report. They have to report anytime they fill a prescription. So you come in with a prescription, they fill it. As soon as you are handed that prescription, they have 5 minutes to fill it. They also will correct the data. Whoever's dispensing it is reporting it, and they're responsible for actually correcting that data. We're talking about humans here. Unfortunately, humans sometimes make typos or make mistakes in data and things like that. Even with electronic prescribing, someone is still typing in the information. If it's at the doctor's office or if the pharmacy has to add information, there's still some different times that you can have errors, and those can always be corrected, and we actually require them to be corrected. They can contact, if someone sees, let's say a doctor or someone sees an error in the PMP, they can contact the pharmacy directly, or they can contact OBN and we will contact the pharmacy to get that fixed. The data is used by many, many different people. So it's used by prescribers, obviously, to check patient information, to see if they picked up their script, to see if they have any other scripts that may be at risk. I mean, most of the time we don't know if our prescriptions interact with each other. That's kind of why we have doctors and pharmacists and stuff, is they're the ones that are supposed to know if there's some type of possible interaction between the prescriptions we're getting. Pharmacists obviously can see it as well for the same reasons. Law enforcement can see it, but only if they have an actual case and a case number. Law enforcement is not yet allowed to use it to try to find problems. They're only allowed to use it when they have a case. We are very strict about giving access to people, and we will take access away from someone if they're using it inappropriately. We take it very, very seriously. Community health providers, health departments, mental health departments, identifiable data is limited. So prescribers and pharmacists, law enforcement, the Oklahoma State Health Department and the Oklahoma Department of Mental Health and Substance Abuse Services gets identifiable data. We have a few other, Oklahoma Healthcare Authority. There's a few other entities that actually get access to the identifiable data. But obviously the public cannot get access to that, but we do allow for de-identified data to be released. As long as confidentiality, which we'll talk a little bit more about, but as long as confidentiality is maintained, if you have a town of like 50 people with one doctor and one pharmacy, we're probably not going to be able to give you that information, because then obviously you're going to know what that particular doctor is prescribing, what that pharmacy is dispensing. So we definitely want to make sure that we're not trying to compromise anybody. So there is that. If you do request data, there is some of that. So a little bit more on that. So accessing the PMP data or the PMP itself, the actual system. Prescribers and dispensers actually get direct access to the PMP itself. They can actually go to oklahoma.pmpaware.net. So if I have any doctors or pharmacists on this, make sure jot that down if you don't have an account already. You can create an account, and healthcare providers, so pharmacists, doctors, nurses, anybody who works in a hospital or clinic or anything like that, they actually have access to our PMP, and then we're also connected to 30 other states to check the PMP. So all of the contiguous states, so all of the states that touch Oklahoma, plus a second layer out besides Nebraska. We're not connected with Nebraska yet. And then the military, we're connected to the military. So you can also see if you have a patient who may also be getting prescriptions from a military doctor or something. But 30 other entities, 30 other states we're connected with. I mean, we're connected all the way, Puerto Rico, California, Colorado. I mean, we're connected all over. And because, in this day and age, people don't just stay put in one place. They also travel. You may get hurt on vacation, whatever it happens to be. Non-healthcare providers, like I said, can get de-identified data. We do have a request form. We have some limited data on our website, but you can always submit. You can ask us for a request form. You can email pmpadmin@obn.ok.gov, and you can request the data. We'll have you fill out a request form just as a formality. We can give, basically, like I said, any type of data about anything with regards to PMP as long as confidentiality is maintained. So if you have, a small community or something like that, we're going to have to expand. Instead of looking at a town or a zip code or something like that, we're going to have to expand it out a little larger, just so then that way we're not, causing any problems with, if there's only one doctor, one pharmacy in that area. We don't want that. That would be obvious that they're the ones doing it. So we want to make sure that we're not, compromising anybody's confidentiality. And that is required by law, that we cannot release information if confidentiality is not maintained. So most of you probably are already aware of the importance of the PMP, but in case you're not, we're going to talk about this. And I'm going to go in detail. This slide will have like a little bit of information on it, but I'm going to go in a little more detail than even just what the slide says. So healthcare providers, will start there. Healthcare providers can use it to become safer prescribers. Sometimes you don't know what your patient is taking. They may not remember. So I had this one doctor who he actually had a lot of college students. He was contracted with a lot of the different universities to provide psychiatric services. And the problem is, mom and dad are the ones who filled the script. Mom and dad are the ones who picked up the script and did everything for the kid. Well, now the kid has moved away and is now at college. He has no clue what mom and dad would pick up. He has no clue what he was getting. So fortunately, the doctor was able to run the PMP and able to see, okay, this is the prescription you're taking, and this, you've been on this type and this quantity and milligrams and everything. So we'll just maintain that, because it seems to be working well. Without the PMP, the doctor would have been like, okay, well, I guess we're just going to have to figure it out and maybe start playing around with different scripts. You definitely don't want to, once someone is maintained on a certain prescription, and once they're an adult, you can't call mom and dad anymore and start asking questions. They're now an adult, and HIPAA, has a lot of restrictions on getting patient information and talking about patient information with other people. So it can definitely help with safe prescribing. There was also a doctor who had a lot of elderly patients. He would go to the different elderly communities, retirement homes, nursing homes, those types of things, and was actually the doctor. And a lot of them, unfortunately, may have some memory issues. They may not know the names of all the drugs they're on. And so the PMP obviously can help with that. It really, if you think about it, for the healthcare provider, it's just another piece of the patient's medical record that they can get access to. The patient may fill out when they last had surgery, or what type of medications that they're allergic to, or something like that. But the patient may not know always what type of drugs, medications that they've been on. Also, like I said before, sometimes the patient doesn't know that the combination of prescriptions they're on may actually be dangerous or risky or have interactions. I mean, there are some drug combinations that you don't know that have bad interactions with each other, and the doctor would be able to see that and then say, hey, maybe we need to change this prescription because it can actually cause some problems with this other prescription or something like that. So, I mean, there's a lot of stuff that it can do, that you can use it for as a prescriber or as a pharmacist that can actually help the patient. And also, one of the things that a lot of the doctors don't know is it can actually help protect their DEA. So for instance, we have MyRx, and it can actually show you every single prescription that has been filled using that DEA number. And if there was a forgery, or if there was even just an error or something, it can be fixed. And if there was a forgery or something, it can obviously be investigated to make sure that something wrong isn't happening, or we can catch the person who's doing the forgeries and everything. So I kind of think of it as like your credit score. So you want to know what's on your credit report. You want to know if someone did identity theft and took out a loan in your name or something like that, you would want to know what's on your credit. So people check their credit score and things. Well, this is kind of the same thing as that. You want to make sure you know what's on your DEA. And so if you check that regularly, you can kind of protect yourself. And if you find something wrong, you can identify it and let us know before it becomes a huge problem. Now, non-healthcare providers, this can help your community, your different clientele, stakeholders. You can identify trends in your community. So, you could identify if there's been an increase in a certain type of drug being prescribed. You could look to see if there's even a decrease. So maybe you have put in some money into the community with resources, trainers, things like that, and now you're seeing a decrease in opioid prescriptions or something. You'll be able to use that and say like, wow, whatever we're doing is working. Let's see what's working. And then, like the second point, you can allocate resources. So if you're seeing an increase in a certain type of prescription drug, and then maybe you're also seeing an increase in prescription drug overdoses or something, you would be able to then allocate resources for maybe addiction treatment or prevention, those types of things. I know a lot of different people also use it to obtain grants and then also obviously maintain the grants. There's a lot of grant reporting that's required. I do all the grants that have to do with the PMP here at OBN. And so I know exactly what you guys have to do. I know that you have a lot of data that you have to submit. So you can always ask us for that. And we'd be more than happy to help provide that information. And then let's see. So I'm going to kind of wrap this up a little bit. We have a lot of different things that we're trying to do. We're creating on-demand videos, on-demand training videos. We're making sure that when we're not available, so OBN is open Monday through Friday, 8:30 to 5. Obviously, doctors and pharmacists and people, healthcare professionals and things like that work outside of those hours. But they may need help with different training sessions and things and just aren't available to come to any of our trainings. So we're working on-demand training videos. So then that way at any time, let's say it's slow, you can just pop on the video and you can learn about some different things. And we're working on making them like, some of them are going to only be 1 or 2 minutes. Some of them are going to be a little longer if it needs to be more detailed. We're working on some live streaming training as well. So we'll have like live tutorials where you can log on. We'll have a link and then you can log on to those live trainings and it'll be on different topics as well. Also, OBN is going to have a podcast soon. We obviously do training on request like today. We have informational flyers on our website. Some of these are from Department of Health. We work very, very closely with Department of Health. And then also we have the user guide on the actual PMP system. So if you need help with the actual PMP, we have a user guide. There's also, we have an FAQ on different things on our website as well. So we're trying to provide more things at your fingertips. So then that way you don't have to contact us. You can kind of help yourself a little bit. And then my information is right here. There were a few other things. I'll come back to this slide, but there are a few other things I did want to show you that I'm over that might be a little bit helpful. I'm going to just flip through some slides real quick. Oh, no, too far. Let's see. Okay. Just FYI, in case we have any like doctors or anything like that in here, if you need to register with OBN, you can go to our OBN registration.ok.gov. So if there are any practitioners or pharmacies or anything like that, you can register with us. And then it's free. It would be free for tribal, IHS, federal. It's a free registration. So it's not like, you're going to have to, you or your entity or anything. If you're private, so if you work in the private sector, it's $140 a year. But if you do need to register with us, and then if you're registered with us, you also would get access to, we send out emails, we send out different flyers and things like that to our registrants about different, just kind of like little informational bulletins that we send out. So there is that, but let me go back here. So if you need to contact me or OBN at all, you can go to our website, ok.gov/OBNDD or obn.ok.gov. That's our website you can go to. Here's our phone number that you can contact us at if you have any questions or concerns or anything. I encourage everybody to, if you are a healthcare professional, get access to the PMP if you don't have it already. If you have anybody in your office, an office manager, a nurse, anything like that, they can also get access for you as a delegate. So definitely register, get the information. It's very helpful. I mean, it's one of those things where even if you very rarely prescribe controlled substances or dispense controlled substances, it's still something that can be helpful to you. And if you're a community health person, entity, anybody like that that's trying to help with prevention or treatment or anything, definitely reach out to us. You can go to our website as well and look at some of the data. We update the data and we're kind of adding some different features and everything, but definitely jot down or do a screenshot or whatever you need to of my contact information, because we definitely are trying to reach out to the community and let them have those connections with us. So then that way, there's a lot of different laws that have changed that have allowed us to do more things than we used to be able to do with the PMP data. All right, I'm going to open it up to questions if we have any. If not, I can always go through some of the legislative changes.
Cool. Yeah, thank you for the presentation, Jessica. And you guys can take yourself off mute if you have any questions or drop it into the CVent chat either way. And I'll quickly plug too, if you guys get PMP data from Jessica and you want help analyzing it or looking at it, Southern Plains is happy to help you do that too. And I'll drop our technical assistance webpage in the chat as well. But yeah, any questions for Jessica? I did have a question. So I work on an opioid overdose grant. So I think about, and I've been working on the PMP, as you know, just some PMP stuff. So I think about it with opioids a lot too. And I know that there's been more conversations lately about stimulant use increasing, and the PMP would also track stimulant prescriptions and stuff too, right?
Yes.
Do you know if there's been a rise in stimulant prescriptions as well, or is that?
Yeah,
Is it
so let me actually, my screens are, whenever you have multiple screens, and then I'm on this Zoom, it's like I'm missing my mouse. So let me go. So everybody kind of defines stimulant a little bit different. And some only define so when you're talking about prescription stimulants, so if you're talking about prescription stimulants, some people only include like Adderall, Ritalin, those types of a Schedule II type of stimulants. But then some people also want to definitely include all of the stimulants when you're talking about, I'm going to show you, I'm trying to do a screen share with my other one. Do you see the website? Is that what you see? Okay. So right here, so this is stimulants right here. This is Adderall and Ritalin and Vyvanse. So you can see like you see it's these, this is like Adderall and Vyvanse and stuff. Ritalin, and this is only through the end of 21, 22, it's still going up. So you see a huge increase in that. It's still increasing. It's a pretty sharp increase. And then also if you include like phentermine and those types of like weight loss stimulants, they are also skyrocketing. So they're kind of going through the roof as well. And then obviously with that, and this is our public website where I said you can go to it and see the different scripts and everything. The only drugs that are increasing are stimulant type drugs. Benzos are decreasing. Opioids, like this bottom one is benzos, it's decreasing. You have opioid, MMEs and everything are decreasing. You have opioids over time right here, decreasing. Like everything else is decreasing besides these stimulant drugs. And then either they're staying pretty level or you have the ones that are increasing. And then obviously meth is the illegal side of it. So illegal stimulants are obviously our number one killer in Oklahoma of drugs is still methamphetamine. It's increasing significantly. We're seeing huge, OBN just had, so last year we had the largest meth bust in the history of Oklahoma. And last week we had the largest meth bust in Oklahoma history. We topped the previous year. So everybody was freaking out last year with the amount of meth that we seized. And then it was more than double. It was about double this last week. We seized like 500 some pounds of meth, which is just it's just astronomical. That's just not heard of. So yes, we are seeing an increase in stimulants. So there is the National Drug Institute and the people who study like drug trends. Eady, I think his name's John Eady. He actually was one of the people who said we needed to figure out how to stop the opioid epidemic before it was an epidemic. Like he actually identified that and said, we are about to be in the worst like drug epidemic that we've ever seen. And he said that years before anybody else even said it was an epidemic. He is now saying that we are in and have been for a while in a stimulant epidemic. That not just illicit stimulants either, prescription stimulants as well. Fortunately, prescription stimulants don't have the overdoses like opioids. So fortunately, there's that side of it. However, illicit stimulants obviously have a huge rate of overdoses. We saw another increase from last year of stimulant, like meth was going down in a little bit in overdoses, and it's caught back up where we have more last year than the year before. So we're seeing an increase in meth overdoses. And then obviously there's also pill parties and things where people are bringing their Ritalin and Adderall and abusing it and things like that. So, I mean, you do have that side of it as well. So, but yeah, stimulants definitely. So we always do the top 5 drugs. You had alprazolam, which is a benzo. You had oxycodone, hydrocodone, tramadol, and zolpidem. And zolpidem is a sleep aid. Zolpidem is no longer a top 5 drug. It's now like Ritalin and Adderall and stuff are now the top 5. They're in the top 5 drugs. So they've worked their way up, and now they're in the top 5.
Wow. Yeah, thanks for sharing all that. That is definitely good information to know. I saw that headline about the meth bust. I did not know that it also was on piggybacking off of another recent record breaker too. Wes had a question. He said, does the PMP delegate have the same access as the registered provider?
So they have the same access except for states. So some states that we're connected to do not allow delegates to be able to see prescription data. It has to be the actual doctor. So there are some states that a delegate would not have access to. But outside of that, in regards to Oklahoma PMP, they have the exact same access. They can submit data. So if they also are like let's say a pharmacy delegate or something like that, they can submit the data. They would not be able to do any edits to the data. So if there's errors or something, a delegate wouldn't be able to edit the data. It would have to be the pharmacist that actually makes those edits. But in regards to like searching patients and things like that, they have the exact same information, the exact same access. Also, just kind of a pitch, if you are a healthcare provider or anything like that, we have integration. And integration is where the PMP can connect directly into your electronic medical record. It is free for prescribers. It is not free for pharmacies, but it is free for prescribers. So if you have an electronic medical record or electronic health record, EHR, EMR, definitely get with your IT people or something like that and ask how you can get integrated. It's a pretty simple process. And you can get it directly linked into your workflow. So you don't have to get out of your EHR, log into the PMP, check it, log out of the PMP, log it back into your EHR type of thing. It's just, you pull up the patient, it'll automatically search that patient into the PMP and bring it into their EHR record. And you can look at it right there. So integration is a huge time saver, and it's also free for now. So definitely, that's a good thing. So just a few things I know were some of the concerns prior to this year. We had to where we were limited to county level data. So we would only be able to give you county level data. That has been changed to where we can actually, like I said, we can give you any level data as long as confidentiality is maintained. So even like zip code level, as long as it's a bigger zip code, or city level, things like that. So you can definitely request that information. We can pull it. We can pull age information. We can pull gender information. We can pull like specific types. So family practice versus pain management versus family, I mean, like there's different specialties that if you're looking at, how many opioid prescriptions do family practice doctors do versus an oral surgeon or something like that. There's even those types of things. We have a lot of information that's now available, whereas it used to not be. And then obviously, if you need just more like general type stats of like this county, how many scripts were in this county or whatever, we can obviously still do that. Also, prescribers if you're a prescriber, you get a quarterly prescriber history report that is emailed to you. And then also it's on your login account. You can actually kind of get an overview of what your prescribing looks like and how many PMP searches you've done, what is the drug that you prescribe the most often, those types of things. It's actually pretty cool. It's like a good overview because doctors see patient to patient. And so they don't realize what their overall practice looks like. They don't know what prescribing in general looks like for them. And so even if you are if you're a community health professional and you go to doctor's office or doctor clinics or something like that, and then they're like, and you're just doing some education on safe prescribing or something, you wouldn't have access to it, obviously. But you could tell the doctor, hey, listen, log into your account, log into your PMP account at some time, whenever you feel like, pull your prescriber history report, and then you would actually be able to see what your prescription history is. You'd be able to see that you actually do prescribe more opioids than you realize. You may not, the last patient you saw may not have got an opioid, but the 30 before that did. And so you can actually see that, and then they can compare, and they can actually get a better view of what their overall practice looks like versus patient to patient. So those are just some different tools that when you're talking to the different people, that's helpful. I also worked really hard, and I had for the last several years of changing our ID requirements for picking up prescriptions. So for a long time, if you picked up a prescription, technically our law said it had to be a driver's license, a state ID, a military ID, or a passport. That was it. That was the only thing you were allowed to use to pick up a script. What you use to verify employment, so like I-9, we actually use that exact same law now. So everything that's in the law about what you can use to verify your identity for employment purposes, which includes still driver's license, state ID, passport, those types of things. But for people who are 18 or older, and actually people who are younger than 18 as well, it includes tribal documents. So CBID card, or some type of, like, a lot of tribes have their own like tribal IDs. All of those are all allowed. It has to have a unique number on it though, because they still have to enter the number. So it can't just be like a letter from the tribe or something. Like, it has to be an actual identification. It doesn't have to have a picture though. So it could be the blue card, it could be whatever. And then also, if you're under the age of like 16, it could be a parent could use their own, like the kid doesn't have to have one. And then if you're over 16 but under 18, you could use your school ID. You could use social security card. Like, we've really opened it up to where our intent is never to prevent someone from being able to get their medicine. That was never the intent. However, we also want to protect the patient, and we don't want someone else going and picking up their script and then using it. And then now the patient doesn't have their own medicine and someone else does. And so we still want to protect the patient, but we also want to make it to where it's not a hindrance. I mean, there are people, and a lot of people don't realize this, like, oh my goodness, who doesn't have a driver's license in 2022 or whatever? You'd be surprised. There's actually quite a few people who do not have a driver's license or don't have a state ID, but they may have their social security card, or they may have a tribal ID, or they may have a student ID or something. So those are allowed. So that was a big push that I had made efforts on. In particular, we had worked with a lot of tribes to try to get tribal documents and tribal IDs included. We had worked very closely, which is also kind of ironic that Oklahoma was not Real ID compliant, but yet, like, the Cherokee's ID, for instance, is Real ID compliant. So it was kind of ironic that tribal IDs weren't accepted, although you could fly with them, but you just couldn't get a script with them, type of thing. So I definitely pushed at the Capitol to get that accomplished, and it was done this year. So tribal documents are acceptable at the pharmacy. And so if you have any connections with any tribes or anything like that, definitely let them know if they don't already. And then if you're connected with any like patients or different people that are tribal members, you can let them know as well. We sent out a blast to all of the pharmacies and pharmacists in the state of Oklahoma, so they all have that email. Some of them, as you're probably well aware, people don't always read their emails, so they may still not know. But I always recommend to anybody, if there's a pharmacist or someone like that that just doesn't know, just tell them like, we'll call OBN and OBN can actually verify whether or not it's allowed. So if you have those types of connections, just let them know. And then another thing that OBN has been pushing for a long time, but it's a little more difficult and a little more nuanced. And Casey knows what I'm talking about. But the one thing in the PMP that we don't have is race or ethnicity is not identified in the PMP. As some of you may be aware, race and ethnicity type of things are difficult to even determine sometimes. They're difficult to measure. Sometimes they don't want to say necessarily what their ethnicity or race is, or they're more than one. And do you have them like select all that apply, or is it just that random category that just says like 2 or more? And then that's not helpful at all. So we have been working out, and I've been working with other states about how do we obtain race in the PMP, but also make it useful. Because it's not on your driver's license. It's not on a state ID. It would have to be self-reported. And then would you want to report your race to your pharmacist? And so there's just some hurdles we have to work through and work on. But that is something that we have been trying to figure out how to do in the future. It's not going to be anything that we have anytime soon, because there's also some different technical programming, computer type stuff that I don't have any knowledge of, but it does take a little bit more effort than just clicking a button type of thing. So those are some of the efforts that OBN has been doing, specifically in regards to tribal affairs and things. So any other questions? And if you want, like Casey said, you can always unmute yourself if you have, now that I've talked a little bit about other types of things.
Thanks for all those updates, Jessica. And I learned a lot, even though I've been working on this for
Right.
a while now. And thanks
Right.
for your advocacy too. Yeah, any questions for Jessica? Comments?
Just an attaboy. Congratulations, Jessica.
Thank you. You can hear the vacuum cleaner probably in the background now. They're vacuuming our carpets. Just a reminder, if you have any questions or comments or anything like that, you can always email us, PMP, just like prescription monitoring, PMP admin, ADMIN @obn.ok.gov. That goes to anybody in PMP, not just me. And so if I'm gone or busy or something like that, the question can still get answered. The data request can still get filled and everything. That the website I showed earlier with the data, that's going to have even more data. And so you can always go there and collect information. There's going to be other filters and everything. So you can get it by year, by county, by drug, those types of things. And you'd be able to get the actual number. And then if you have any specific requests for your community or anything like that, you can always request that information. If you need anybody to come out and do a specific training somewhere or with your group, or if you need anything like that, definitely let us know. I am more than happy to come out or do a virtual or do whatever you guys need. Or if you know a group or a clinic or doctor's office or whatever, or hospital that might benefit from a training or even just some information about PMP and things, then definitely give them my contact information and we can get that scheduled. I know that a lot of times, and it's not just, I've had this literally, at OBN, we've had this our entire existence, basically. It's like we're the cops and you don't want the cops at your door unless you want the cops at your door type of thing. Like, I get it. Like, unless you're calling them, you don't really want them to show up. And unfortunately, law enforcement shows up in most of the time people's like worst day. That's not at all what like OBN is. So there's not, I know the hesitancy. I mean, I even have this in private practice. I mean, I've been in this for a while, and most of the time they don't want to talk to with OBN at all. But fortunately, we have some resources that can be of a huge benefit. And ever since I have been at OBN, I started going to these different like state tribal meetings and IHS meetings and things like that to try to gain a partnership. Even with the Southern Plains Tribal Health Board, I've met with them on multiple occasions. So I pride myself on the partnership that we have with tribal entities and the tribes and IHS and everything. And I feel like we can only make it better. So definitely, if you ever need anything, let me know. I will stop talking now. So then that way, if you need to go to the restroom or something before your next session, you'll have at least like 10 minutes to do that. I tried to kind of tailor this presentation more to like a FYI type of thing in a conversation, versus some of my typical types of training, because I know the audience is a little bit different. And a lot of the audience probably will never have direct access to the PMP. So, but you can still get the data, de-identified data. So it's still useful to you, and it can still help what your goals are.
Yes, definitely. Yeah, we've back when you can only get county level, even that, we created a few like opioid prescription reports for partners, and it was really useful for their program planning. Well, thanks for your wonderful presentation. Like Jessica said, we can end early. You guys take 10 minutes. Don't answer your emails, just take the extra 10 minutes. So, and yeah, and we'll see you guys at our next sessions. I think we'll begin at 10 a.m. again tomorrow is when the sessions will start. We will have, you can take the evaluation for this session. You'll get an email afterwards, or you can also click the survey button on See Event on this session webpage. But again, thank you to Jessica, and thank you all for being here. Have a wonderful day.
Thank you guys. Bye.